Radiation therapy is an important treatment option for many patients with breast cancer. Today on Health Talk, a physician expert in radiation medicine will discuss the treatment and how it works to destroy breast cancer cells. So stay tuned for an informative show. We're up next. Hello, I'm Dr. Eric Mazer. Today our topic is radiation therapy and the treatment of breast cancer. Joining me is my friend and our guest, Dr. Pradip Prathare of the Radiation Medicine Department at Norwalk Hospital. Pradip, thank you for joining me.
Most welcome. It's a pleasure to be with you this morning.
I've worked with Pradip for, I guess, 25 years, forever. He's actually, to me, and I've said this to you off camera, just really one of the model radiotherapists, one of the best radiation oncologists I've ever worked with. So it's really an honor to have
Eric.
But we're going to talk about radiation therapy for breast cancer. And maybe I can just preface this. We've been using radiation for therapy, I guess maybe since the 70s, since we started to talk about breast preservation.
Right. Oh, yes. Of course, radiation predates all of that. We used to treat radiation with radiation after a mastectomy. But in the 70s, the movement became conservation of the breast. So you did a partial mastectomy and followed it up with radiation.
And I remember, that was pretty tough on the patients. There was a lot of skin reaction. I remember weeping and redness, and we always were worried about damage to the lungs and the heart that are behind the breast. So that it was an effective procedure, but it really carried with it certain costs.
Absolutely, and what has happened over the years is how do you target the tumor and spare the healthy tissues? And lots of research has gone into it, lots of developments in the equipment have occurred, lots of software and the computer planning has helped us bridge that gap. One is actual image guidance, because in the older machines, we only could treat. We never saw what we were treating. So now with the new arms that can give you the image of the part being treated, you're that much more confident that you're really treating only the breast and not treating the heart, not treating the lung, etc.
I mean, I know, dating back to the 70s, there were no CT scans. We didn't have, and now you reconstruct this three-dimensionally and interface that with the radiation machine, right?
You're so right, because in the old days it was a two-dimensional X-ray, forward a frontal view and a lateral view. But now, with the help of a CAT scan, we can develop a three-dimensional model. What we do is position the patient in the simulator in the treatment position, and then we take a CT image from top to bottom, and each slice can then be integrated to develop a 3D model of the patient's anatomy, the whole chest wall, the breast, the heart, the lungs, the spinal cord, the voice box, and then we set these parameters into our planning computers, and our dosimetrists physicists help us put together a plan whereby we can bring these beamlets of radiation, not just one big field as in the old days as a tangential sweep, but we can do what's called intensity modulated radiation therapy, IMRT, or VMAT, where we basically can bring beamlets, and as the patient is being treated, the machine turns around the patient so that we can get tiny beamlets intensifying the radiation where we want to, and when it comes to a sensitive part, the beam turns off and that part skips over, etc.
So it's really at least two or maybe three. You're able to get better images of what you're treating. We can create them three-dimensionally before the treatment.
Correct.
And then is the beam itself much more accurate than it was 20 years ago?
Because the older machines were the cobalt machines, where the beam could not be defined precisely. The edges were a little blurry. The newer machines, the linear accelerators, give you very precise beams, and instead of a big, like if you imagine a flashlight, as the further out it goes, it becomes a larger and larger beam. Now we can use a laser light kind of a concept, that we are able to precisely treat only that area with such a sharp edge that anything beyond it, the dose falls off very, very rapidly.
And I guess it's just for folks at home, you need to reach a certain level of radiation exposure to kill the cancer cells.
Right.
But you don't want that necessarily that same dose affecting sensitive tissues like the heart and the lung.
Absolutely. So one of the ideas today is deep inhalation breath hold. Imagine the heart is right behind your rib cage, and if you're only going to be treating as a tangent, the surface of the heart may be in the beam. So you have the patient take a deep breath, and that moves the chest wall and the breast away from the heart. Now you have that much extra room to play with. Now we can do that, but how do we ensure that that's exactly what's happening during the treatment? And we have the technology now. We can throw a pattern on the patient, and prior to it, during the simulation, we have built a model, said this is the position where the chest wall needs to be in order to deliver that treatment. And when the pattern matches, the beam goes on. If the pattern falls, the beam goes off.
So this is a really technology which is affecting us all with our cell phone, has really affected the practice of radiation oncology. It seems like it's almost nothing like it was 25 or 30 years ago. So maybe we have some images. Maybe you can take us through the planning of a breast radiation course of therapy and how it is so effective and how you're minimizing side effects.
Right.
So we have the images that are going to come up in a moment, and we'll take, as I said, our viewers right through. So here's the room in the general. Take us through the series of images.
So this is the modern linear accelerator. You see the couch on which the patient lies. That couch has a capability of moving up and down, sideways, etc. And the modern couches have 6 degrees of freedom. It's just not XYZ, meaning up and down, sideways. It can roll and pitch and yaw. So you get that degree of precision, which is actually required for, say, stereotactic radiosurgery. The arm that you see at 12 o'clock on the top is the treatment beam starts.
So that's sort of
there.
the head of the machine.
That's the head of the machine.
Head.
That's where the beam starts, and at the bottom, the panel that is retracted, you can move it back into place and take an image of that particular field. So if the radiation is going through the, say we're treating a lung, and you can see the whole image on that other panel. The ones that you see at 3 o'clock and 9 o'clock, they're cross beams. They can also come up, and the machine can then now swivel 360 degrees. With one revolution, it has captured the CT image of an entire part. Unlike the diagnostic CT scanners, which do it slice by slice, this does a whole volume at one time. One sweep gives you the entire part in a CAT scan image. This is the patient now on the table. The table has been moved up into the treatment position. The therapists are positioning the patient where we want to treat. You can go to the next one now. And this is an idea of how all the
those are complicated slides. So
the idea is it's showing you the different beams, the arcs of rotation, the yellow little arcs. That this is how the beam is going to swivel around the patient. And there's a view from the transaxial on the upper left. At the bottom is the corona.
So the upper left
is the cross section like a CAT scan.
Up from the feet.
Up from the feet.
And those two dark things are the lungs inside the chest wall, right?
Right. And the one below it is a coronal section that you're looking front on, and the one on the lower right would be the lateral view, and that basically is a 3D dimension. And it tells us what is happening. And that little green little character in the corner is called Cosmo. It's basically a computer-generated model. It tells us exactly the patient position because it tells us we are at the front, side, which is left, right, etc. We can look at a little bit close-up of one of those images now.
Next.
And so that will tell you exactly how the beams are going, the blacks of the lung, as Eric said. And we can go to the next one. And then ultimately, the interaction of all these beams results in a dose cloud. So now we have the dose clouds. Far out you go, it'll be 10%, 20%, etc. So this is the 100% dose cloud that you can see is precisely tailored to treat all the region of
that's the sort of yellowish area. On the patients may be a little confused. Again, we are looking up the patient from the feet. Those two black things are the lungs. This is if the patient's been sliced down across the chest. And the yellowishness is the dose cloud?
Correct.
And sort of the lump that one sees at the top of the yellowish on the left, which is actually the patient's right breast, is the breast.
Correct.
Okay.
And then we can go to the next image. And so this is one of the techniques we're trying to reduce the dose of the heart. This would be in free breathing, and you can see the yellow circle is outlining the contour of the heart, and the other yellow line outside is contouring the chest wall, and anything beyond that you can see the breast. Now, we can have the patient take a deep breath, and to the next image will show you what happens. Here you can see with a deep breath, the chest wall and the breast is moved that much further away from the heart. So now all the dose distribution, as you saw on the right side, now on the left side you can see has moved away from the heart.
And so what we're really saying here is a little bit of extra dosage to the lungs is less dangerous than a little bit of extra dosage to the heart.
Absolutely, absolutely. And moreover, when we do this, we need to be sure that this is exactly the position. Patient hasn't taken too deep a breath or has let out too much air. So we have technology that can project a color pattern on the patient's chest during the treatment, and that pattern is matched to our planning computer's pattern, and when the two precisely match and interact, we know it's in the field.
Do you have them breathe easily during that process, or do you have them breathe in?
During the treatment, we ask the patient, take a deep breath and hold. And when they're holding, this middle bar, it should all remain green. If they take too deep a breath, they'll move over to the left or the right beyond the parameters. And then when that happens, the beam stops when it comes back in. So we have them hold their breath for a few seconds, treat, and then go back in and treat again once they're able to come back within that bar.
And this is the last picture. What are we seeing here?
So this is just a close-up. This is the pattern projected on the patient, the green and the white. So one is the one that has come from our treating planning computers, and the other one is being projected on the patient. So the two need to just blend in and out. So you want to see a little bit of green and white interplay, so knowing that that is the range in which the patient should be in.
It's really amazing. It's so different than the old days. Again, and I'm emphasizing this for folks at home because I think people still carry around images of the old Cobalt machines, and this is really incredible. We talk about targeted therapy. This is literally targeting the X-ray beams only where they should be.
You're right. Radiation was probably precision medicine from the very many years before that became a common term for medical oncology drug therapy. Now we have the precision is treat only the cancer, minimize the dose to the normal tissue, and imaging plays a great role. We use MRIs, PET scans, CT scans, and all of these different modalities are brought together in planning computers so we can create and 3D the actual tumor and then all the normal structures around it.
And it sounds like also the machine is interacting with the patient right on the table.
Right on the table, because in the past, if we did the planning on one CAT scanner and the patient is on the treatment machine, how do we know for sure that this is exactly how the treatment was planned? So having the CT imager on board, that's on-board imaging, or real time, we're able to confirm that and ensure safety.
And Pradip, we have a little bit less than a minute left. Explain to folks why does the normal breast, there's normal breast tissue and there's cancer. You do give full radiation therapy to parts of that normal breast. Right. Why is that less damaging to the patient than the same amount of radiation to the lung or the heart?
Well, there are certain parts, organs that are rapidly dividing cells suffer a radiation injury faster than less rapidly dividing cells. So that is one of the problems with tissues like the bowel, etc., which suffer a radiation injury at much lower doses than
tissue. So it really is
tissue.
that certain tissues tolerate the radiation better.
That's one. And the bigger help is cancer is a rapidly growing tumor. So they suffer a radiation injury to a greater extent than normal tissue. When we fractionate on the weekends, etc., the sublethal doses of radiation, the normal tissue is able to repair much faster and better than the cancer cell.
And we've run out of time with that. I wish we had more time. Fascinating stuff. So this is not your father's radiation therapy. And it really becomes remarkably effective and non-toxic. So unfortunately, we have run out of time. I want to thank my guest today, Dr. Pradip Prathare, for joining me on Health Talk today. And thank you for watching. Remember to share your questions and comments with us. You can just call Community Relations at Nuvant Health, 203-852-2250. See you next time.
When I was 6, I had one thing on my mind. When I was 6, my days were spent playing basketball every chance I could. When I was 6, my dream was to make it to the NBA. When I was 6, my mom had a stroke. I'm Paul George, and I want you to learn the signs of a stroke fast. F-A-S-T. F, face drooping. A, arm weakness. S, speech difficulty. T, time to call 911. Because the sooner they get to the hospital, the sooner they'll get treatment. And that can make a remarkable difference in their recovery. Protect the ones you love. Spot a stroke. F-A-S-T. Fast.
What are the differences between standard radiation therapy and hypofractionated radiation therapy in the treatment of breast cancer? Our guest on this week's Health Talk will answer this question, as well as others you may have on the role of radiation therapy in breast cancer treatment. So stay tuned for this week's Health Talk. We're up next. Hello, I'm Dr. Eric Mazer. Hypofractionated radiation therapy in the treatment of breast cancer is today's Health Talk topic. My guest is Dr. Pradip Prathare, who specializes in radiation medicine at the Whittingham Cancer Center at Norwalk Hospital. Welcome back to Health Talk, Pradip.
Thank you, Eric. It's a pleasure to be here.
So we're talking about hypofractionated radiation therapy for treatment of breast cancer. That's a big mouthful. Why don't you explain what that means to people at home?
Well, I hate to use the word what was standard and now hypofractionated because the goalpost keeps changing. So hypofractionation is now our standard, actually. What we used to traditionally do for breast cancer would fractionate the radiation treatments to a series of 30 treatments. Patients came in daily, Monday through Friday, for 6 weeks. And the idea was you use the principles of radiation. What happens is you're giving sublethal doses of radiation every day. You're waiting for the cells to move in their cycle because they're mitotic, or the time when they split into two is the most sensitive.
So you want to hit these cells when they're actually dividing and growing.
Correct. So as you fractionate them, some of them are moving into that most sensitive type of the cycle. If you have a tumor, you're allowing greater parts of the tumor to be oxygenated. Again, they are more sensitive, so as you're killing off the surface of that tumor, the inner parts are getting more oxygenated, etc. There's the repair, sublethal damage is being repaired, things for normal tissues. That was the fractionation idea.
And normal tissue doesn't divide generally as rapidly as cancer cells, so that you're able to...
Their ability to repair radiation injury is greater than the ability of a cancer cell. So instead of 32 treatments, and that was inconvenient for lots of women.
That's really 6 weeks.
6 weeks of
daily
spending
radiation.
20 minutes, 30 minutes in the department, commuting, coming, taking time off work, etc. So they started wondering
Can
whether...
I ask you, before we just leave that, I think most people at home have no idea what it feels like to get radiation therapy.
Right.
Does it hurt? Do people, I mean, what does the patient complain
No,
of?
I mean, it's as simple as going in for an X-ray. You're lying on the table, you cannot see the beam, you cannot feel the beam. Over time, you're going to see the effects of the beam. So for the breast, basically, you're going to see a little skin reaction like a bad sunburn. Later on, when it heals up, that breast may remain a little more sensitive, but that's the most that these radiation beams can do. But yes, we want to prevent the complications. One of the feared problem is lymphedema. So how do we strategize and minimize that risk?
Yeah, I mean, I used to see a lot of that as a practicing oncologist. People probably saw it in their grandmothers who had these terrible swollen arms that were just clumsy and unsightly and uncomfortable.
And in the old days, the trend was doing more and more aggressive surgeries. So not just regular, you did a very big axillary lymph node dissection and then followed it with radiation. So those who had radical mastectomy and radiation had those problems. Today, it's very low risk. We have learned sentinel node biopsies can give us as much information as a node dissection, so that has cut down those risks dramatically.
Point out, so for folks at home, the lymph nodes and the lymph channels under the arm help to drain excess fluid from that arm. And in the old days, surgery would remove a lot of that, and then radiation therapy would damage a lot of the remaining. So you could get almost, I wouldn't say no flow, but a real backup in flow of that lymph fluid, and they get lymphedema.
Correct.
So how about this hypofractionated? That's sort of going back to higher dose with each treatment.
Yeah, so then they started wondering whether shortening the course would be just as effective and not more damaging. So you need to have a parallel. So they've done various trials, and we've come down to the point where we know that we can effectively give that same dose in a matter of 20 treatments as opposed to the full 32. And many times we can just stop at the 16 treatment where we treat the entire breast 3 weeks, or those that are at a little higher risk, we give a boost to the tumor bed to maximize our chances that the tumor will never come back. So that's the hypofractionation. That's one treatment modality where we treat the entire breast. Now, there is a select group of patients where the tumor may be so early and low grade that we can do only partial breast. So when we do a partial breast treatment, we treat only that particular quadrant where the tumor was, and we bring in beams of radiation from different directions, and that would be partial breast radiation, which can be done in 2 weeks. So 10 treatments, you're done.
And I think this is important to point out. When we have a successful treatment, which used to be lumpectomy and radiation therapy,
Right.
so much work then goes into minimizing the side effects. This is really a lot of new work, not in improving the cure rate, but getting the same cure rate and improve. Is that right?
You're absolutely right. And in fact, we're going to this point where we can say, can we now start defining patients who may not need the radiation after their lumpectomy? So we have come to certain levels where we can look at the tumor size, the tumor grade, do an oncotype
I
score.
was just going to ask if you're using genetic profiling.
Yeah,
as
and then
well.
and the age of the individual, and say, okay, your risk of a local recurrence without radiation is, say, 5% or lower. You don't need to go through radiation. We can hold off. Sometimes you do know that if you have radiated somebody a second time around, you may not be able to re-radiate within a certain number of years. So you might say, if your risk is low, hold off on the radiation for now. We will watch you very carefully, and if you have a recurrence, we will treat you then.
Maybe you could explain to the viewers at home why radiate at all. You have a mass in the breast, you see it, you take it out surgically, the margins are clean. You know, why, they may say, I'm sure your patients ask you, why do I need radiation?
Right.
The tumor's already gone.
So it's basically an insurance. If in the clinical trials have been done, say for somebody with node-negative disease who had a lumpectomy alone, they were randomized to radiation versus no radiation, and the recurrence rate without radiation was 29% versus 10% with radiation. So you've reduced it by a third. So now it's a no-brainer. Now, you do go through lots of other treatments where the benefit may be only 3 or 4%, and yet you would want to go through that. So to each his own. Some want treatment if it improves your risk profile by 1%. Others say,
Right.
I want it like 90%. So we give you the choice, we give you the information, and you make up your decision. If you're making a wrong decision, we'll try to educate you, saying that's not the right decision.
And the reason local recurrence happens is because there are microscopic deposits of tumor cells.
Right.
Statistically, they may be there. We can't see them. We have no way to test for sure to know whether they're there or
Right.
not. So we use this risk stratification, if you will, as
Correct.
you said,
Yeah.
using a whole bunch of information to try to make that decision. How do you decide whether to use a hypofractionated approach or, say, a standard 30 treatment approach when you see a patient?
Well, in fact, I'm going to reverse it on you. Our approach of hypofractionation is our standard approach. If somebody has a very large breast or has some certain factors where we know that she's very sensitive to treatment, has a lot of skin burn issues in the past, etc., we might go to the older 6.5 weeks, but that is very rare. Most of our standard care is going to be the hypofractionated treatment, and for those select group with early low-risk tumors, we will do the real hypofractionated, meaning the partial breast, the 10-day treatment.
Mm-hmm. So that's, again, all approach to make life more convenient for patients and to reduce their side effects.
Absolutely.
What kind of questions do you get from patients before they go in for radiation therapy?
Well, one of the concerns, of course, am I radioactive? And yes, if we use radionuclides that are ingested, say for thyroid cancer, we're giving them I-131 pills, they would become radioactive, or we put radioactive seeds in a patient for prostate cancer, or if in the older days, partial breast radiation, we used to implant radioactive material. If the radioactive material is in you, you're radioactive. But all of these are all external beam treatments. The moment the beam is off, you're not radioactive, completely safe to hold your kids and babies around, hug them. There's absolutely no
That's
risk
an interesting.
profile.
I hadn't thought of that one. Let me also ask you this question. I think women have heard, we all heard that radiation causes cancer. They say you don't want, mammography, you want to minimize the dose of
Right.
radiation. And yet here we're using radiation to cure cancer. It seems paradoxical, I think, to people at home.
In a way, it is. The uncontrolled, scattered low-dose radiation that might occur, say, if you're living in an area with, say, Chernobyl type of a
Just gonna
disaster.
say, where there's a nuclear power plant.
And so those are carcinogenic. The therapeutic dose of radiation, if at a lower dose something is becoming carcinogenic, meaning creating cancer, by the time you reach the higher dose, that has already been inactivated, so it doesn't. But yes, mind you, there is a small risk of cancer in patients who have had radiation treatment. And we have to decide upon, say, in terms of breast cancer, the concern is a angiosarcoma of the breast, happens in a fraction of a percent, and we would have at that point no choice but to do a mastectomy. So now, on a potential, everything in life, as you know, is a risk. Taking an aspirin is a risk. So would you trade off a small fraction of 1% to not having radiation and reducing your chances of keeping your breast by 90% or improving your survival by 40, 50%? It's a no-brainer.
Yeah, and I think that that's something that folks may not realize. In everything we do in medicine, there's always a risk and a benefit. Any medicine you take has side effects, and I mean, they probably see it by all these drug ads on TV. This drug can do everything, including kill you, but we want you to have it.
Right.
But yes, there are always risks with everything we do. It's always a risk-benefit analysis, and usually the benefit is far outweighs the risk in order to do something. The side effects from the radiation therapy that patients are getting, what do they complain about as they're going through the course?
Well,
used to hear about esophagitis, soreness on swallowing.
that's a good point. If somebody has an early stage breast cancer, or only doing the tangential breast alone treatment, the side effects are minuscule. But if somebody has a little more advanced cancer, where we're treating the breast and the lymph nodes, these lymph nodes under your armpit continue as a continuous chain above your collarbone, close to your throat. So there you will get a little bit of crossfire, so a little bit of a sore throat. Esophagitis, meaning difficulty swallowing, because the esophagus is right in the nodal basin there. And those are temporary side effects which basically clear up. And again, esophagitis, because the esophagus is lined by epithelium that is rapidly dividing, and so it causes
And that's sort
like
of
a
the
skin
magic. If
reaction.
cells rapidly dividing, they don't
Yeah.
tolerate radiation
So
as well as
with
those
the
that-
IMRT treatments, etc., we are able to carve out these areas. We shield the thyroid gland, we carve out the esophagus to the best possible, but it's either you spare normal tissue completely, but you might spare cancer, or you treat the cancer and you have to accept the side effects on the normal tissue, which are temporary.
We have again about a minute left, but people are hearing a lot of ads for radiosurgery and gamma knife and all these sort of fancy things. We're the only gamma knife radiation oncology in the Northeast. What is all this stuff?
Well,
Is it really?
These are basically, ultimately, it's the radiation coming out of a machine. Now, gamma knife is typically a
About 30
cobalt-based machine.
seconds, so it's going to have to be
But a
quick
cobalt
answer.
machine where you're getting multiple sources of cobalt in a shell, and the patient goes in, they're all focused to a tiny spot. That's gamma knife. Whereas linear accelerator-based machines, basically you get little pinpoints of radiation, but the machine turns around, giving them from different. So gamma knife is a static machine. This one is
So these are all different machines that can achieve the
they do the
basic
same
thing.
thing,
So
yeah.
it's a little bit of advertising hype and
Oh,
not really meaningful in terms of the
Absolutely.
patient. Okay. But I want to thank my guest, Dr. Pradip Prathare, for joining me on Health Talk today. Great discussion. And thank you for watching. Remember to share your questions and your comments with us. Please call Community Health or Community Relations at Nuvance Health 203-852-2250. I'll see you next week.